book and the second edition of the book that we just came out with not too long ago is really focused on making judgments about epidemiologic evidence in a sophisticated and thoughtful way, which is something that is done quite commonly by, as I'll describe later, in setting clinical practice guidelines and setting policy. And there's been relatively little attention focused on making those kinds of informed judgments thoughtfully and methodically. So we'll see that, and of course, given the nature of what the center does here, of trying to talk about it specifically through the lens of healthcare interventions. So the challenge, as I see it in epidemiology, is that the commands of the subject matter and methods are both necessary but not sufficient to evaluate the research. And I think a lot of the field has evolved where these are separate universes of people who are, say, the true experts in cardiovascular disease epidemiology sort of live in a different world from the methodologists. And the separation of methodology and the subject matter experts is a problem because we need to integrate those perspectives to make informed, intelligent judgments. My little whirlwind history of epidemiologic methods, really starting in the early 1980s, the statistical tools expanded considerably. Tools that are now obviously part of the very familiar repertoire of logistic regression, looking quantitatively at the impact of misclassification of measurement error. It evolved into more of a theoretical understanding at a very basic level, recognizing that there is not a cause of disease, but it's a multifactorial process. The notions of counterfactuals, of the conceptually what causality means, is trying to compare what did happen to what would have happened under other exposure situations. Exchangeability, and then the missing data framework for, again, it gets a little esoteric and it's gotten more esoteric, but trying to sort of frame what do we mean when we talk about something causing disease. So causal inference has really evolved quite a bit, and it really is the unifying theme for what we're trying to do with epidemiologic studies, is we're trying to design them and interpret them with that goal in mind. And the tools that are now commonly applied of directed acyclic graphs, DAGs, some use of multiple bias analysis, and so on. Again, with the intention of trying to use observational data to make causal inferences. It's putting aside for a moment the research that is purely to measure prevalence or the frequency or just the occurrence as a pure descriptive phenomenon, but really the bulk of what we do, we can try to use words that evade it and talk about associations, and it's just a statistical pattern, but ultimately the applications in almost all cases are towards a real causal inference. So the, again, my sort of perception of why we've made maybe more limited progress than we would have liked in the application of epidemiology relative to the methods. And I think what's been part of the disconnect is that the advanced statistical tools and conceptual tools, which have become increasingly daunting, to me at least, it's hard to bring those to bear in making a practical assessment. And it's interesting, I'm going to be at a panel of talking with real causal modelers, and my role is to be sort of a consumer of that, and how do we use all of that to make better informed judgments for the things we want to do for clinical or public health policy application. So we often end up, after all this esoteric work is done, we say things like the evidence is inconclusive, or there may be biases, or we're not quite sure yet, and that isn't terribly helpful. So I think that certainly it comes up in training epidemiologists, these sort of phases of understanding how the field works. It often starts, of course, if they're coming to graduate school, they're often very excited about the prospects. They think they've discovered this amazing thing that's going to answer all their questions, and they start off with great enthusiasm. And then by the end of maybe the second course, they've learned about all these biases and errors. And so often going through a phase of where the recognition of the possible errors leads to this excessive caution. Well, we don't really know. It's possible that. And it's which is true, but I think there is really not sufficient attention to distinguishing likely from unlikely contributors. Plausible is different than likely. And to reconcile in a case-by-case basis the need, the scientific caution with the need for practical decisions, of making a judgment that is specific to the subject matter of the question being asked. Because it may be that for one purpose, that degree of uncertainty is fatal. We can't act on it. In other cases, we live with it and move on and make an informed decision that takes it into account. I think that these days of tight funding in particular, there's a growing demand for the research to have impact. And what that to me means, in order for research to have impact, it can't be the claim that we're going to produce the definitive final answer, but rather we need to draw tentative conclusions based on incomplete evidence. And as I'll describe, the question about the marginal benefit of new research is, will it help us make a more informed, more appropriate decision? Does it move us in that direction? And this is, I think, especially true in epidemiology because it's being used extensively by non-experts. And I include in that, and I don't mean to insult anyone, but healthcare providers, people who are clinicians doing their job and doing their work and reading the journals, I think are increasingly encouraged, pressured, motivated to use epidemiologic evidence. And you can't expect that that's going to be done by investing extensive time in learning all the nuances of the methods. So what's the goal? The aspiration, at least that we set out for in the book and that we're trying to sort of inspire, is the full and objective use of all the relevant information for causal inference, to use our understanding of the methods to guide how we evaluate it, and ultimately to come out after this examination of the evidence with a reasoned and helpful assessment that really is a bit tailored to the consumers of the research, if it's policymakers, if it's other epidemiologists, if it's clinicians, of trying to use the evidence not to slant it or to bias it, but to explain what it says or has to offer in terms that are meaningful to the audience to whom we're speaking. So this is maybe obvious, maybe basic, but it's something that in trying to be more systematic about how we assess epidemiologic evidence, or should. And I'll go through these with a specific example in some detail, so hopefully it'll be less sort of abstract. But the first thing we want to do is describe the causal hypothesis in explicit detail. Not in these sort of very broad terms like, gee, we think this drug has something to do with this disease. That's not helpful. But really trying to get into the details, because that's how the evidence works. I find it a useful exercise to say, okay, in an imaginary world where we had no constraints of money, ethics, anything is in the way, what would an ideal study of this issue look like? What would be the definitive approach to answer this question? And that sets the benchmark then for the third step of saying, okay, what are the important ways that a feasible real-world study deviates from what would be ideal? That's where the sources of bias arise, when we have to basically make compromises to do the research. Then integrating the evidence, taking all these blocks and putting them back together again, and then interpreting and how to explaining how to use that information to make judgments for applications. So the example I'm going to show, it happens that some of these authors are from Oregon, the Portland area, but it's a project that I'll describe in a bit. I'm going to go through this as one example of examining their study, but also then leading into some work that I'm doing that's data analysis in progress that address this same issue. And the topic, as you can see there, is the question about induction of labor in low-risk women and the effect on pregnancy outcome. So the context. Labor induction is really quite common. Nearly a quarter of all births in the US in 2008, and I don't think it's gotten lower, but are induced. And the goal, of course, the reason induction is done is because at that point in time, there is a judgment made that it's time to deliver, and that will be beneficial for the health outcomes of the mom and the baby. Severe medical conditions that develop during pregnancy, of course, demand intervention by either induction or prelabor cesarean, meaning a cesarean without a trial of labor. And so that those are not what we're talking about here. Those are medically demanded inductions. What we're focusing on here are milder conditions where there's discretion. There's a judgment to be made of whether to proceed with the delivery or not. Now, in general, the earlier babies are born, the higher risk they are for a range of health problems. And so all other things equal, in the earlier parts of pregnancy, say before 39 weeks, before full term, there is a disincentive from the baby's health point of view to intervening. You want the pregnancy to continue to 39 weeks. Now, this study is focusing on term gestations, 39, 40, 41 weeks. And here, one of the big outcomes of concern is whether there is going to be an increased risk of cesarean delivery if you induce labor versus allowing it to proceed spontaneously. There's been a question for a long time. And one of the innovations, this group in particular, but others as well, there are many studies done which were comparing the risk of cesarean delivery with induced labor versus spontaneous labor, which is maybe of theoretical interest, but you think about it, that's not a decision anybody gets to make. You don't say, I want to deliver now, let's have it be spontaneous. It's really the choice is between induction and, as they call it, expectant management, which means not inducing, basically. Kind of a funny expression that's sort of the norm in the field, but it basically means not decide, you either decide to induce or you decide not to induce. And that's the comparison that the clinician has some say over. So the study that they did was based on a large sample of US births, which had the needed information from the birth certificates. There were different forms of the birth certificates in use, and these were from the 12 states that had the necessary information. And they included nulliparous women, so no history of prior cesarean, sort of at low risk in that sense, and singleton births, no twins, vertex, at 39 to 42 weeks gestation. They excluded women who had chronic hypertension or pregestational diabetes, again, because those risk factors have bearing on induction. And it excluded women with a series of conditions only from the induction group, not from the expectant management group, because at a given week in gestation, I'll come back to this, you don't know what the future holds. You only know the status at that time. And so when you look at the decision in a given week, you have to allow variation in what's going to happen thereafter. You can't go back and fix it or change it based on the future. That's not the way time moves in one direction, and you're trying to simulate that. So they compared those with induction of labor in a given week to those who delivered later. They excluded women who had a spontaneous delivery in the same week because it was unknown when in the week it occurred. And they looked at a series of outcomes for the mom and for the baby, the Cesarean, APGAR score, other neonatal health outcomes, and were able to control for the usual set of covariates from birth certificate data, which is largely sociodemographic and a little bit of healthcare information. So the results, what they found is that cesarean occurred in 26% of inductions and 28% of those in the expectant management group, and so there was not an increased risk of cesarean, in fact, a slightly reduced risk. Operative delivery, again, close to the null, but perhaps a slight increase in risk. Interestingly, and I'll come back to this, macrosomia was extremely rare among inductions, the baby birth weight over 4,000 grams, with an adjusted odds ratio of 0.33. And I'll come back to what I think some of the implications of that are. Chorioamnionitis, an infection of the chorioamnion, was also rarer among induced than among spontaneous, among induced deliveries versus expectant management. APGAR score being low, which is what you don't want, so a slightly reduced risk of an adverse outcome for the infant with induction. a markedly reduced risk of meconium aspiration, a small reduced risk of ventilator use, and an overall reduced risk of morbidity in the offspring. So, interpretation of this study is, again, the data speak for themselves. Induction of labor at term is associated with a lower risk of cesarean. They acknowledge the potential for uncontrolled confounding given the limited information they had from the birth certificate, and I think made the reasonable inference that other things equal, the women who were being induced had perhaps were more likely to have problems than the women who were allowed to continue. And so the argument was that if you're going to predict a bias, you're going to say that those who had an induction may have had some subtle problems, and the fact that they still had a lower risk means it could be even more favorable than that. So now the methods. Now I'm going to sort of juxtapose that and, again, the article and the approach to it, but asking now these sort of framing questions of what do we make of this? So the first issue of the causal, describing the causal hypothesis in fine detail is trying to get more specific about the exact nature of the exposure and the outcome, the disease. Timing is often something that is ignored, and this is applicable here. The mechanism that's thought to be applicable, and this is not so much in the classic sense of biological plausibility, but when you can specify the mechanism by which it's thought to operate, that often makes a prediction about groups that will be more or less affected. It has implications for the kind of results you would expect if you have an idea of how it might be operating. And so the benchmark then for the methods is how effectively has this refined hypothesis been addressed? And then, of course, in looking at the results, how closely do these results fit with the hypothesized pathway? So looking at this, again, the hypothesis on labor induction pregnancy outcome is, as indicated there, the general one, that this clinical decision to induce labor at term does not increase cesarean delivery or other adverse outcomes. Now, again, it is presuming that the decision to intervene is truly elective. I learned in obstetrics, they don't like, you shouldn't use the word elective. That's not well received because it implies, oh yeah, why not deliver? What the heck, let's go put her into labor. That it is a decision that is based on some perceived clinical benefit, but in analyzing these data, comparing those who do and don't receive the induction, obviously it's assuming that that is truly unrelated to the other factors, the outcome. Now this is interesting because, again, I don't know if there are any obstetrical experts in the room. I welcome help if there are, but they didn't really talk about the mechanism. Why should inducing labor be more likely to lead to cesarean delivery than spontaneous or vice versa? I mean, why should there be a difference that way? And I think part of it is the idea that managing labor from the outset certainly could lead to more favorable outcomes than spontaneous labor. It could also be that there is not an adequate sort of anticipation or preparation for vaginal delivery at this point in the pregnancy. And so, but there's not a lot of discussion of how this is supposed to occur. Why would this be a factor? So the deviation of study methods from the ideal, there's only so many ways we can go wrong. At least I'm a lumper when it comes to not listing 20 biases, but there's only 3 or 4 things we get wrong. And it's, and these are actually in my sort of priority order of how common and how impactful they are. And one of the big ones, of course, is good old-fashioned confounding. In this case, as I'll talk about it, confounding by indication. That it's familiar, it's kind of boring, but it's so obvious it may not be theoretically interesting. But the problem is, of course, this non-comparability of those who receive one exposure regimen versus those who receive another. Limitations in measurement, I think, it can be pretty impactful in exposure or health outcomes, and then, of course, selection bias or random error. So let's now think about what would be the ideal study of this. And of course, one of the elements of an ideal study would we we would have randomized assignment of labor induction versus expectant management in a homogeneous population. Pretty straightforward, pretty easy to conceptualize. I think that in an ideal world, we would have a detailed evaluation of what happens thereafter. Let's look at the course of labor and delivery. Let's see what's going on in terms of the pathways, what's leading to the decision to do a cesarean or not, and to try to really understand how these choices sort of play out in regard to the delivery. And then, of course, in terms of the health outcomes, we would look broadly at a whole range of factors that may be affected. So now, major sources of error. This is where I think, again, I think that rather than listing 5 or 10 or more things, I think that the most valuable way to approach this is to zero in on the big ones. And in my experience, it's between 1 and 3. If you have more than 3, it's really a problematic study. And you have at least one that is really like, if somebody says to you, okay, now be honest, why do you think your study may have gotten the wrong answer? It's like, okay, let me admit it. This is a structural problem. I can't do anything about it, and this is why I'm concerned. And I think that it's sort of a useful soul-searching exercise to try to articulate that. So we form an explicit testable scenario of bias. I think of bias not as the thing that's not causality, but it's a specific hypothesis that can be tested, and you can look at data to see whether it's confirmed or refuted. And the formulation of the bias hypothesis should be specific enough to be testable. Not like, oh, I'm worried about it, but it should be saying, I believe that this group differs from that group in these ways, and that will cause a problem. And so at least it's trying to move it in the direction of being a hypothesis to be examined. And then using the data from within the study, but also outside the study, to judge the likelihood and magnitude of impact that bias has had. So here the big one, again, as I said, and is obvious, is this problem of confounding by indication. That the decision on induction is a subtle decision that is made in the course of pregnancy. It involves patient characteristics and preferences. It involves the clinician's reading of the signs and laboratory tests, the patient's history and prior pregnancies. It's a very nuanced sort of judgment that's being made when you think of the reality of, okay, you're at this point in pregnancy, what do we do this week? What do we do now? And that those factors may be important. I think there's 2 directions it can go, though. One, of course, as the author said, is that if the woman is having problems, that may make the clinician more prone to induce, and those same problems may, of course, be predictive of adverse outcomes. But I think it's also possible that the decision to induce may be because they think there's a good chance for a vaginal delivery. In other words, when you have spontaneous labor, you didn't decide that. That's just where the woman got to. And unless there's some compelling reason to know that it has to be a cesarean, so let's give it a shot. Let's see how it goes. When you decide to induce, you're doing it, making a bet that it will be successful, that it will lead to a vaginal delivery. And so I think that there's a sort of a potential for a bias going in the other direction. And it's also, I'll come back to this, but is ignoring this sort of third option of what do you do in that week? Well, you can do nothing. You can induce, and you can also say, look, we've got to deliver the baby. We're going to do a cesarean. We're not going to have a trial of labor. We're just going to go for it. And that is, of course, out of this equation of a prelabor cesarean, which may effectively remove those who are at high risk of cesarean anyway. So the evidence on this, not a lot of data on the covariates to try to get a feel for how these groups may differ, not presented in detail in the paper. The comparing of the unadjusted and the adjusted odds ratio suggested very little confounding by the factors they did measure. But now coming back to that observation, I think there's a reason that very large babies showed a very much reduced risk of cesarean delivery with induction, because they wouldn't induce if the baby weighed over 4,000 grams. They would deliver, and if they had to deliver, they thought it was time to deliver, they would likely do a cesarean without waiting. And so I think there's very dramatically reduced risk of macrosomia with labor induction is perhaps indicative of that process. As I said, it's challenging to capture the full array of what determines the decision to intervene, and we quickly run up against the limits of what birth records can do. The profile changes over time. This is a week-by-week decision. It's funny, when I was working with clinicians, when I describe our study, I'll come back to some of this, but we would say, they would say, well, the decision is, do we induce at 34 weeks or 35 weeks? I would say, no, the decision is, do you induce at 34 weeks, yes or no? And then a week will go by and you'll decide again. Because it's hard not to get this idea, like you look at it in retrospect of the whole story and the timeline, and all you have at a given point in time is what you know at that time. And so the profile changes for a given pregnancy week by week. And as I mentioned, the birth certificates, though, are limited both in the predictors of who gets induction, but it also, in the clinician decision-making algorithm, we don't have a lot of data to know why they would have thought a given pregnancy could be successfully induced and lead to vaginal delivery or not. That takes different kinds of data. Measurement error, I think, is not a terribly big deal here. I think they know whether they induced or not. Exposure is accurate. The outcomes are, I think, accurate but limited, again, given the data sources. And the missing part to me is the detailed studies of the course of labor and the infant health outcomes. This is just for the sake of completeness to say these are not on my list of biggest worries. And this one I may have one worry. It's confounding by indication. The next step is integrate the evidence. So we would consider the affirmative support for causal effects, looking at the causal hypothesis and evidence bearing on the hypothesized biases, including both the likelihood but also the magnitude and direction of that. So in this case, again, the data show at a slightly lower risk of cesarean with labor induction. The evidence on confounding is incomplete, but likely to be biasing it towards a less favorable view for the induction. But then the selective use of labor induction may tilt the results in the other direction as I described. Finally, and something I think that's under-taught, under-considered, that's not good grammar, but not considered enough in epidemiology and an evaluation of evidence, is how to tell the story of what that evidence offers. And those of you who've dealt with media run into this, sometimes or just informal conversations with friends that aren't in the field or colleagues, like, oh, I read this article, what's going on? And you say, well, let me explain. And there's a certain tone to that is different than when we speak to our, the colleagues trained in the same technical area. And so I think that the goal is to provide an informed, integrated, objective judgment regarding this potential causal effect. To provide, if you're speaking to other epidemiologists or other researchers, explain in a little more detail what the sources of uncertainty are, where the research leaves off. I think that talking to policymakers can be challenging, but I think that it's trying to provide the information they need to make an informed cost-benefit evaluation. You're providing one bit of input into a bigger, more complex decision, and you want to have that weight of that input be accurate or appropriate to what we know. And then finally, of course, if you have to distill it down to a sound bite, it gets harder and harder to do justice to it. But I do think that there are better and worse ways of doing that to really distill it fully. So again, the inferences for epidemiologists or other health services researchers is easy. I'm not going to repeat that, but confounding is the problem, and the birth record is incomplete for addressing that fully. So this is more, again, back to the explaining it to a lay audience. So if I were explaining it again, there's my statement that I'm made up for researchers. A record-based study suggests slightly lower, not higher risk of cesarean, limited by the covariate data, and it's restricted to induction versus expectant management only. So now we're going to distill it a little more. To the media or the public, it's interesting when you talk to me about this. Imagine now your hypothetical situation. You're talking to a woman. She's at 39 weeks pregnancy, and she's having a discussion about whether to induce labor or not. So now you're the expert. You've read the article. What should I do? Which I hate those questions, but that is the kind of way it gets distilled. And to say a clinical decision to induce doesn't appear to increase the risk of cesarean, and of course that needs to be integrated with all the other considerations for making a decision about the timing of delivery. But it's not saying we don't know what to do, or it's trying to give that little bit of input that the data offers to be factored in appropriately. Now finally, in going through this process, the issue of the weight of evidence for future research, the goal, of course, of new research is to shift the weight of that evidence. So if you want to be sort of practical about it, it's trying to say that after this study, we will have a different level of confidence, we will have a different message about the body of research as a whole. So doing similar studies, as I said, only adds precision. I sometimes conceptualize it as doing a whole big long project and ending up with another dot on the meta-analysis. That's not a real good use of resources, especially if there's any substantial body of research. So adding precision alone is not not only not very exciting, it's often not all that useful. So the study has to really address one of the major, not minor, limitations in order to enhance inferences, and again, provide substantial value in advancing knowledge, either causal hypothesis or designing research which can really nail the question of a hypothetical bias that's of concern that could potentially have every bit as much value. So in trying to approach this, which is what we are doing, we felt that there were a certain number of features of new research on this topic that were to be considered. One is the need for a detailed clinical profile to address confounding. As I said, we talked with clinicians and would basically say, what are all the things you would want to know in making a recommendation at this point in pregnancy? What information would feed into your decision-making algorithm? Now, it's limited by their self-awareness to a degree, and they can't just say, oh, it's intuition. That doesn't help us. We can't abstract that one. But when it does come down and say, oh, I'd look at this sign, and I'd see about this, and I'd know about her history, and et cetera, that was what we considered in designing the data collection. Consider a longitudinal series of decisions with time-specific information on covariates. So as I'll describe, it has to be recording when things happen. One of the things, birth certificates are a wonderful resource. I've used them a lot, but they're worthless when it comes to timing because they're telling the story at the end. The woman developed preeclampsia at some point. I don't know if it was at 32 or 40 weeks. I have no idea, and that is a very big difference in its implication. Trying to create homogeneous categories at risk for interventional delivery so that it's clinically meaningful. What are the subgroups of patients that, where the subgroup membership is in part what's driving the decision making? And then to look pretty broadly at the range of maternal and infant health outcomes. So conceptually, we started with the goal of approximating a randomized trial as closely as possible. First, let me describe a real randomized trial that just came out a few weeks ago, which interestingly was looking exactly at this same issue that this article I described, a large randomized trial of induction of labor at 38 to 40 weeks gestation. And lo and behold, in a well-done, it came out in New England Journal, as I said, a few weeks ago, induction was indeed associated with a lower risk of cesarean. It kind of negates all my hypothetical biases maybe to a degree, but that is what it indicated, and with no measurable increase in infant morbidity or mortality. Now, what we undertook was a related but distinctive, and we were looking at an earlier period of gestation, 34 to 38 weeks, when the clinical consequences are greater and broader. It's not just about cesarean delivery. There are a lot of other considerations when you're in the preterm and early term range. So we are working with a population, a database from Women and Infants Hospital over the period indicated there, 2006 to 13. And our basic goal was to identify a set of patient conditions where intervention is neither mandatory or it wouldn't be considered at all. So, for example, we looked at hypertensive disorders as one of the major groups, but we excluded severe preeclampsia because that's not a discretionary condition. That's a mandatory delivery condition. So they're not going to help inform the judgment. That's too late for that. Looked at, again, the hypertensive disorders, diabetic disorders, and intrauterine growth restriction. And again, these were chosen in response to the way clinicians organize their world. Which bin is this patient in, because that's how they're going to be making the decision. So what we did is we developed these very detailed clinical profiles. So we looked at each week of gestation. There are 4 things that can happen in a given week. You can induce labor, you can do a cesarean without labor, the woman can go into spontaneous labor, or continued pregnancy, also known as expectant management. Now, as I said, we tried to collect all the information that would bear on this decision regarding intervention, and we looked in great detail at when these conditions began. So we had information on the timing of onset. Fortunately, we were able to connect not only with really great clinical researchers, but also with a really talented statistician who is an expert in these sort of new and ever more esoteric approaches to propensity scores. And so what we are generating now, as we speak, hopefully, these week-specific propensity scores to identify groups that, the way I think of it, they're effectively randomized. That there is women with an identical profile, some of them are getting induced and some are not, or intervened on, and let's just say more broadly, and some are not. And so one of the questions I think that's useful to ask in observational studies of healthcare is, first of all, is there a group that is effectively randomized? If there's not, it's very hard to do observational research. And the reason there is this random variation, or effectively random variation, is clinicians make different judgments in the face of ambiguity, which is good for our study. Whether it's good for the patients or not, I don't know, but it's good for the study. And secondly, that practices have changed over time. That the willingness to intervene before 39 weeks has undergone a fairly radical change, so that by looking at several calendar years, we'll have some women who had a given profile, let's say in 2008, who got intervened on, same profile in 2012 didn't. And again, that's raw material for this observational study. In the analytic methods, which you'll see no algebra because it's all conceptual for me, but basically, a woman's experience, the way that it's being analyzed is looking at a woman who received an intervention and comparing her outcome to other women of identical profile who did not receive the intervention. And it's, of course, dependent on having those women that are comparable. And the more of those you have, the more precision it contributes to the analysis. So at the extreme, if a given profile, if nobody is induced, it doesn't tell you anything. And if everybody's induced, it doesn't tell you anything. The more overlap there is, the better. And so that's what we're in the process of discovering. And so what we're doing is assessing alternative outcomes at individual level by week of gestation. So had this 35-week induction not been done, here is what her outcome we believe it would have been. So hypothetical outcomes. Won't talk about these in detail, but it's looking at a range of indicators of maternal and infant morbidity, including cesarean, but also looking at pregnancy complications, length of stay, infant conditions that are common, including health care burden, if you will. So finally, last few slides. So a colleague was laughing at me as I was describing this, and so I just decided to adopt his phrase that was using to ridicule me of what is epidemiologic wisdom. So these are just the last few slides in closing, but again, and this is different than sort of intellectual brilliance or whatever. It's how to sort of make use of the data in the optimal way. And it requires, I think, at least familiarity with the critical principles and methods. And at least what I find the hardest thing to do is, on the one side, I have this repertoire of ideas and tools and methods, and then I have the substantive question on the other side, and it's knowing how to connect those, what to bring to bear on a given topic. Focus is informed by the topic of the concern, and it considers both the qualitative and quantitative impact of error. Subject matter knowledge of exposure and disease. One of the things that I've become increasingly appreciative of is that if you're going to study a disease, you not only need to know the biology, you need to, how does this play out in the real world? How do people know they have the problem? What is the symptom? What is the standard way that it's dealt with? How do they enter the healthcare system to be counted? And having that kind of working knowledge that you get in your subject matter research areas is really vital to designing the studies. And so it's true for the exposure as well. When we're asking about confounding, in this case we're looking at labor induction, well, what are the factors that bear on that? What are the covariates? What else do we need to measure? And again, the etiologic process, the advantage of knowing something more about the whole etiologic process is it lets you refine this database and this information. And finally, in explaining it, it's accepting the nature of the target audience, not lamenting the fact that they don't all have the technical skills you do, and accepting this sort of challenge of doing justice to the evidence without invoking highly technical jargon and technical reasoning, but to come out with something that is informative and useful and true, that is helping in the decisions or the issues that they're facing. So with that, thank you. I'll be happy to take questions.
Thank you.
Thank you.